Okay, we're going to talk about seizure disorders. So, epilepsy is defined as a condition where seizures are triggered recurrently from within the brain, which means there is no external trigger. Um, it's two or more unprovoked seizures that occur more than 24 hours apart. So, having one or two seizures in a row does not necessarily mean you have epilepsy. You need to know the interventions for epilepsy or for seizures. They are to take seizure precautions to adequately pad the rails. Frequently, we see that the crib rails are not adequately padded because they don't have pads that fit the crib rails very well. Med administration, we need to make sure that the patients are on the fewest amount of meds possible. So if they're going to see their neurologist and every time they go, they're having a lot of manipulation done to their dosing and they're adding new things, and they end up with 3, 4, 5 seizure meds, these children are going to be they might have their seizures controlled, but they're going to have a lot of deleterious effects of the abundance of medications they're being given. So the general rule is that most neurologists like to treat with the fewest amount of medications possible. We need to provide good education to the family about how to handle a seizure, when to contact a provider or 911, and how to manage their medications for their loved one, including maintaining a regular schedule. Frequently, we see that there are some barriers and lack of resources that lead to families not treating seizures the way they should be treating on a regular basis. And then we also want to encourage normalcy. The closer to normal we can get any child with a chronic or lifelong illness or disorder is going to really promote their living to the fullest extent and having fewer complications. So the medical management, we're going to focus on controlling seizures or reducing their frequency. We might not be able to stop them altogether, but we really want to be able to control them, which would be like rectal diazepam or something that is fast acting for use during the seizure, and then reducing the frequency by using medications like Keppra, or I'm trying to think of some other ones, and my brain just went completely blank. Anyways, anticonvulsant therapy. We're going to help the child and the family learn to live with the seizures with minimal bad effects or outcomes. There is a table on page 1396 in the Ricci text that lists all the different anticonvulsants. Like I said on the previous slide, we want to treat with the fewest amount of drugs that have the fewest possible side effects. We need to find the right time that these meds can be given to control a patient's seizures. So if anticonvulsants really aren't helping to control the seizures, regardless of which ones they've used or how they've added them together and combined them or different times, then a child may need to have a hemispherectomy, which is the surgical procedure to remove literally a hemisphere of the brain. Other treatments that are done are ketogenic diets and placements of vagal nerve stimulators. Um, the ketogenic diets are still very experimental. They don't have a lot of information on whether they provide good seizure control or not. Yeah. So these are some of the different types of seizures that I want you to know about. There's focal, generalized, unknown types, and febrile. So a focal seizure is one that begins in one foci or spot of the brain in one hemisphere. These children don't always have unconscious effects. They could be completely conscious and able to speak to you during the seizure. And they frequently do not have a postictal phase because they don't really have an ictal phase where they are unconscious. In infants, some of the signs could be lip smacking, chewing, swallowing, excessive salivation, strange movements with their eyes. And in the older child, we see a lot of picking and pulling behaviors, object rubbing, and strange non-directional walking or running patterns. Within the generalized type of seizure category, there are multiple different kinds. There are absence seizures, which used to be called or can be called petit mal. There are tonic-clonic, which is a grand mal, myoclonic, and atonic. So an absence seizure, they tend to be more common in girls than boys, and we don't normally see them occurring before the age of 5. They last less than 30 seconds, usually, and it can happen many, many, many times throughout the day. It can often be missed as an actual seizure because it's so subtle. It could be children that are complained about in school daydreaming a lot because an absent seizure tends to look like that. Just a gradual staring off into space, a lack of response, and then it's over. The problem is that the more of these that happen over time, we still have some potential intellectual disability that will occur. Tonic-clonic seizures are what most people generally reference when they think of seizures. The tone is the stiffness, so that is tonic. The clonus is the shaking or jerking. So you have periods of shaking and jerking and periods of stiffness. These are extremely common and they are usually the most dramatic type of seizure that we see. Frequently, patients will say that they have an aura of some sort before the seizure occurs, where they might know that it's going to happen. They might have visual changes, smells that don't make sense, like smelling oranges all of a sudden in a classroom where there's no oranges, the smell of burning matches or sulfur, or hearing strange noises. There is a loss of consciousness that occurs, and these children tend to also have a postictal phase where they're almost kind of comatose or semi-comatose, or they're in a really deep sleep for anywhere from 30 minutes to 2 hours can be normal. The safety of the child is really the primary concern with a tonic-clonic seizure, as well as the amount of repetitive seizure activity that occurs, because if they can't be well controlled, again, they will lose function of certain things in their brain, and there will be damage that occurs. A myoclonic seizure, it's kind of a stiffening of the muscles or a jerking, but they frequently don't lose consciousness. If you go to the wakelet for neuro, you'll be able to see some children that have obvious myoclonic seizure activity. Atonic seizures, these were also called drop seizures. It's where you completely lose tone. So a child with atonics type seizures might fall suddenly because they lose the ability to have any tone in their body. They frequently also lose consciousness, but they return to consciousness within a few seconds to a minute. Their postictal stage is much shorter. Febrile seizures are the most common type of seizure in childhood. It's usually benign, but it's really scary. The risk factors for having a febrile seizure is a child that has very elevated fevers, usually. So these are kids that every single time they develop a fever over 102 per se, they're going to potentially have seizure involvement, or brain involvement and then have a seizure. So some of the actions that we take, we're going to institute seizure precautions on these patients. We're going to make sure that we educate parents about the need for controlling their fevers, using rectal diazepam, and letting them know that any continued seizure activity during a fever, if it's not able to be controlled by the rectal diazepam, they need prompt medical attention. These are some of the diagnostics that are done. ECGs, x-rays of the skull to look for damage, CT scans, MRIs, and vigorous history. One of the things that I see very frequently is that children are placed on video EEG, or what's also called a 24-hour EEG, and those tend to not find anything. In the neuro unit that I worked in at the large children's hospital, we had children in there ranging in age with different types of seizures, and they were diagnosed already as having a certain type of seizure and or epilepsy, and we would have them on a video EEG being monitored by a tech who was in the room with them, or in the unit with them, just like a monitor tech you'd see on telly. This is a EEG monitor tech, and they sit in the neuro unit and they watch everybody's EEGs. The parents, or ECGs, the parents have access to a button that they push saying that what they see as seizure activity is starting to occur. And then we correlate that button push to what we see on the monitors. We will have these kids on video EEGs for, oh my goodness, sometimes 5 or 6 days, maybe even longer. And even with attempting to force seizure by hyperventilating them, keeping them awake for 24 to 48 hours, and hyperstimulating them with bright lights, shiny things, and strobes, they still don't seize. So EEGs are diagnostic, but not always easy to show us what we need to know. Looking through to see if there's anything else I need to tell you about this. I don't think so. Okay, so nursing interventions, we're going to try to maintain safety. We're going to make sure that there's aspiration precautions in place as well. When you go in the room of a seizure patient, the first thing you should be doing is checking that there is suction, that it is fully set up, and that it is ready and on and able to suck. Don't just assume that because there is a suction canister on the wall that it works. Always check it. That should be your first order of business when you go into the room of a seizure patient. Checking that, making sure your parameters are set on your monitor, and making sure that you have the appropriate sized ambu bag in the event of an emergency. We're going to do thorough and good documentation, and we're going to give a lot of education to families regarding the fact that the repeated seizures will and can cause intellectual disability, that the child should not play or participate in sports or activities where they can sustain a head injury or a fall, that if they are of driving age, they cannot drive for 6 months after a seizure. They have to be seizure free for at least 6 months until they can drive again. And the seizures should be reported to the DMV. And then we also want to support the families. So this is some of the documentation that we do in in a neuro unit. We also want to have parents be aware that these are things that we want them to be looking for at home as well. We need to know the time the seizure started, the activity that was occurring immediately before the seizure. Were they playing? Were they exerting themselves? Were they watching television or a video? Were there flashing lights? Did they fall and hit their head, and that's what caused the seizure? We also want to know what part of the body was affected first by the seizure. So if the very first thing that starts happening is head jerking, we want to know that. Or is it their right arm jerks out to the side? We want to know in what direction the parts move. We also want to know if there's cyanosis involved. Cyanosis tends to occur in the tonic part of the seizure, which is when there is stiffness. That stiffness, it's pretty much all of the skeletal muscle becomes very stiff. So during that tonic part, we tend to see cyanosis develop and then start to go away while they're having a clonus. So we want to watch and see how much cyanosis there might be and provide supplemental oxygen if we need to. That should also be something that you check and make sure is working in the room when you place a patient who has a documented seizure disorder or they are considering a seizure disorder as a diagnosis. So make sure your oxygen is on and functioning and you have it hooked to a mask and that mask is ready to go. We want to know what eye position or movement they have. All of the eye position and movement, body parts moving, and parts of the body that are affected help to show the neurologist where the focus of the seizure is and if the seizure is, or if the lesion in the brain that causes the seizure is spreading. We want to know if they had any incontinence during or after the seizure. That's frequently the case. We want to know the time that the seizure ended and what their activity looks like in a postictal state. Are they postictal? What does their postictal state look and feel like? And if there is no postictal state, how does the child act after the seizure? Hopefully you all know what status epilepticus is. It is a prolonged or clustered seizure where consciousness does not return in between the seizures. We give basic life support during status epilepticus. We're going to give benzodiazepines like lorazepam, diazepam, Ativan, all of those. So we're going to give those either IV or rectal. Sometimes they also have an intranasal form, but that can be difficult during the clonus part of a seizure. And then we can also give fosphenytoin, which, if you remember, that's one of the ones that can cause neural tube defects in pregnant women. So the benzodiazepines with lorazepam, if we give it IV, we have like a 15 to 30 minute peak. Oral is 15 to 60 minutes. If we give diazepam, it takes longer to work than lorazepam, but we can give it rectally, and it's 10 minutes. IV, 1 to 5 minutes. It's the oral form that takes a little longer. So the benzodiazepines help to slow down the excited synaptic processes in the CNS. And then we use fosphenytoin as an anticonvulsant. It has an onset of anywhere from 15 to 45 minutes, and it alters ion transport, and that overall decreases the synaptic transmissions. But I just need you guys to know that we give benzos, we give fosphenytoin, and we expect them to be working pretty quickly. They don't always, so the kids end up loaded pretty heavily when they come to the emergency room. So we're not just going to see post-ictal state, we're also going to see them kind of gorked out because they've gotten so much, so many of the PAMs.